Yeah. This is just a membrane peeling film for epiretinal membrane, and I would like what I like to do as end stage of my membrane peeling in these idiopathic ERMs or ERMs because of other causes is peel the epiretinal membrane and then see if there is any traction and folds still persisting, and that guides my decision for removing the internal limiting membrane. I would like Dr. Soam's, Murli's and Manish's opinion as to what is their take on this. Do they go by published data which says there's a lesser incidence with ILM peeling of recurrence, or do they weigh it according to the look on the table after removing epiretinal membranes? In many of these eyes are good prognosis eyes with fairly good vision preoperatively also.
Show with eye, I'm almost always try to remove the ILM as well, unless I'm struggling with it for some reason on that day, it's not coming off easily, and it looks good, and then I'll say, okay, I'll leave it. But 90% of the time, I plan to remove both the ERM and the ILM. One, because of the success, because the slight recurrence rate may be about 2%, and two is because there's nothing left to do. If it doesn't work, I've done everything I could. There's no revisiting that patient after that.
I would peel the ILM in almost all the patients, where I'm doing an ERM surgery. Although I know it doesn't really affect the visual outcome, but there is a reduced chance of recurrence. But of course, recently I just read one paper in which they have shown that OCT study of the outer retinal layers, they found that in the ILM peeled eyes, there is a more disorganization of the structure of the outer retina compared to the non-ILM peeled eyes. And of course, this was only evident for the first month. And later on, both the groups looked very similar. So are we really causing more damage by peeling the ILM? That's one. And second, and in the same study, they also found that the visual recovery was much slower in the ILM peel group for the first month.
That is the point. This is a very recent study.
At this point of time, we don't know whether ILM peeling is really necessary. But most of us do because it's easy to do with all the stains that are available. It's not such a difficult procedure, and we feel we should do everything that's possible for this patient. But at the present time, I do have some doubts now after reading that article whether we need to do. Yeah, maybe you could draw a line and say patients with good vision, I would probably retain the ILM, where you don't want the vision to be low in the first month. Patients with poor vision, 618 or less than that, 624, 636, you probably go and peel because the membranes are thicker and maybe the chances of recurrence are more. At this point of time, I don't know.
In fact, that study in ophthalmology is my main point of raising this point, which, and I've become a little cautious that I like to peel the ILM where I see persistent folds still at the macula rather than go ahead and peel the ILM in every patient.
The problem is I have not been able to really make the decision because the retina looks still edematous and you have peeled the ERM and there's some whitening happening. So you can't really judge at that point of time to say whether ILM should be peeled or not. I have found that it's a difficult call to make.
I think once we all have intraoperative OCT, that might help a bit. Yeah. If you're causing too much traction, then leave it. If it's all looking fine, then carry on.
Yes. Second point I would like to raise is that I like to combine cataract surgery with a lot of macular surgery, especially macular hole surgery, because I feel the surgery which we are doing is already cataractogenic, and the second logic being that we get a more complete fill of gas, even if we are using, because we are able to do a better vitrectomy, even if we are using sulfur hexafluoride, which we mostly use in these patients rather than C3F8 now. So I find that these patients, the whole closure rates, at least in my hand, I feel are better with a combined approach rather than with a approach of doing just the macular hole surgery, waiting for 4 months, 6 months, and then doing the cataract surgery. I would like the opinion of my co-instructors on this also.
Shobit, I've shifted to largely doing combined surgery for anybody who's post-presbyopic with a macular pathology or even often with RD. Because if you're post-presbyopic, then you're going to need a cataract anyway. The only slight difference I would make to your shown technique is that for combined surgeries, I always use a 3-piece lens, which is usually a sensor, because sometimes the gas can push things up and you might have to go and reposition it, and it's much easier with a 3-piece lens. And the final point I'll make is, although we tell the patients posture, 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 we don't know how much they posture. So if you're giving them that better gas fill, then even if they're not that compliant, the procedure still works. So for all these reasons, I've largely shifted to doing combined surgery for these patients. It adds about 10 minutes to the operation, and it doesn't make it. It makes it much better, actually.
Let me get the damn cursor there.
And the final point while you're getting that up is, in these days of sutureless surgery, for combined surgeries, I'll still put one suture in the incision, in the main cataract incision, because when you're indenting the periphery, you can lose the anterior chamber. And I'll often take it out at the end of the operation. That doesn't matter. But during the vitrectomy, I want my cataract incision, my 2.8 or whatever incision. If you got a 1.8, you're probably all right, but you can't get 3-piece lenses. So
yeah, that is merited on a case-to-case basis.
For that.
Third, I would like to show a nice film of unusual macular hole repair. This was a patient with a macular hole with this small dome-shaped detachment of the vitreous here, as evidenced on OCT, and it's a young patient, about 16-year-old girl with, why isn't it going ahead? Yeah, no, it's going. So,
is it a traumatic hole?
No.
16-year-old?
It's a very unusual hole. It's caused by a nematode. Okay, and
I think it's not going beyond a certain point.
where is it?
How this technology can just resolve.
Why isn't it moving?
They just
It's perfectly moving. Yeah. You see that worm wriggling, and so we planned a macular hole surgery. First, remove the worm live by doing a limited vitrectomy, keeping the port open and sucking the worm in a syringe, getting it live to the pathology lab for identification, and a regular peeling for the macular hole, as would be done. I would like to raise that in posterior vitreous detachment, I like to use very low suction. It's mostly a manual removal especially in these young patients, then the macular hole surgery as a routine surgery. And what was interesting was the worm was identified as a microfilaria with this double nuclear chain staining in the tail, and we had a very good closure. This is the pre-op, the post-op. This is just 10 days post-operative, and you see the ELM and the ISOS junction already forming back. She had good visual, 6x6 visual acuity post-surgery. So it was a very interesting situation to encounter. And this is the case where I would not touch the lens, because the lens was absolutely clear. She has a long way to go. It's been about 1.5 years, and she's maintaining pretty good lens clarity and vision. Thank you very much.